Today we will discuss fungal infections involving the sinonasal tract. Fungal sinus infections are common, and sinonasal contents are among the most frequently encountered specimens in routine surgical pathology. Therefore, familiarity with these entities is essential for practicing pathologists. There are four major types of fungal infections affecting the sinonasal tract. Allergic fungal sinusitis, AFS, is the most common sinonasal fungal infection. Mycetoma, fungal ball. Invasive fungal sinusitis. And rhinosporidiosis, this is the least common fungal infection in sinonasal tract. Each entity has distinct clinical and pathologic features. We will review them one by one. Allergic fungal sinusitis, also referred to as allergic mucin, is the most common form of fungal-related sinus disease. As the name implies, it represents an allergic reaction to inhaled fungal organisms, most commonly Aspergillus, although many other fungi may be involved. Microscopically, sections typically show fragments of benign sinus mucosa with chronic inflammation. The diagnostic feature of allergic fungal sinusitis is the presence of allergic mucin. The mucosal findings themselves are nonspecific and may include thickened basement membrane and mixed inflammatory infiltrate, including eosinophils, within the lamina propria. The diagnostic feature of allergic fungal sinusitis is the presence of allergic mucin. Allergic mucin consists of thick mucin admixed with abundant eosinophils. Charcot-Leyden crystals are often present, which are breakdown products of eosinophils. Charcot-Leyden crystals are common but not required for diagnosis. In some cases, allergic mucin is composed predominantly of densely packed eosinophils with scant mucin and shows a characteristic tide line or Christmas tree ring appearance. Although allergic mucin results from inhaled fungal elements, the amount of visible fungus is variable. Some cases contain abundant fungal organisms, while others contain very few or none identifiable on routine sections. Importantly, special stains, GMS or PA, are not required for diagnosis, as demonstrating fungal organisms does not change the underlying etiology. Management includes a combination of surgery, anti-inflammatory therapy, and antifungal medications. Recurrence is common, and patients may require repeat surgeries and prolonged medical therapy. A mycetoma, or fungal ball, consists of aggregates of fungal elements within the sinus lumen. Unlike invasive disease, there is no tissue invasion, and therefore minimal or no host inflammatory response. Aspergillus is the most common causative organism. Histopathologic features include densely packed fungal hyphae forming a mass-like lesion with little to no associated inflammation. Sinus mucosa, if present, is usually unremarkable. At higher magnification, tangled fungal hyphae are readily apparent. Treatment is surgical removal alone. Antifungal medications are not indicated. Invasive fungal sinusitis is a medical emergency with a high mortality rate. Pathologists are often required to make this diagnosis on frozen section, where both misdiagnoses and overdiagnosis carry serious consequences. The key diagnostic feature is fungal hyphae invading necrotic tissue. It is important to remember that the presence of spores alone is not diagnostic, as spores may represent saprophytic colonization without tissue invasion. Despite its severity, the histologic findings can be subtle, making this an easy entity to miss. Inflammatory response is often minimal because affected patients are frequently immunocompromised, for example, organ transplant recipients, patients with malignancy, or those with diabetes. In this picture we see in the lower part of the picture, one unremarkable fragment of sinus mucosa. In the upper right corner, we see one fragment of pale tissue. If you do not pay attention, this tissue fragment could be overlooked as mucus. High power view, we can see that it was a completely necrotic tissue. And we see scattered fungal hyphae. We can also see a necrotic vessel with fungal hyphae invading into the vessel wall. So this is invasive fungal sinusitis with angia invasion. This is another case. We see these fragments of sinus mucosa, which look quite unremarkable except some pale areas. High power view we see numerous fungal hyphae invading into the necrotic and still viable tissue. There is very limited tissue reaction. This is because patients are often immunocompromised with organ transplantation, malignancies, or diabetes. Some rare cases are associated with crystals. As shown in this picture, we see completely necrotic tissue with abundant crystals. GMS stain highlights the fungal hyphae in these necrotic tissue. This is a case of invasive fungal sinusitis caused by Aspergillus. Treatment includes aggressive surgical debridement, and systemic antifungal therapy, often amphotericin B. Because amphotericin B is nephrotoxic, accurate diagnosis is critical. Missing a case can be fatal, while overdiagnosis exposes patients to unnecessary toxicity. Rhinosporidiosis is a chronic infectious disease caused by Rhinosporidium seabury. It is endemic in India, Sri Lanka, and Brazil, rare in the United States, and uncommon elsewhere. Microscopy reveals large mucosal and submucosal cysts, sporangia, as shown in this picture. On high-power view, we see numerous endospores within these cysts. These endospores can be highlighted by musicarmin and PAS stain. Surgical excision is the treatment of choice, and antibiotics are ineffective. Recurrence is common, up to 10% of cases. Summary: fungal infections of the sinonasal tract are common and include allergic fungal sinusitis, myxotoma, fungal ball, invasive fungal sinusitis, rhinosporidiosis. Each entity has distinct clinical behavior, histopathologic features, and treatment strategies. Accurate pathologic diagnosis, especially of invasive fungal sinusitis, is essential, as it has direct and potentially life-saving implications for patient management.